Won't you come see about me? I'll be alone, dancing, you know it, baby. Tell me your troubles and doubts. So give a little bit, give a little bit of your time to me. Now's the time that we need to share. Don't send a smile. We're on our way back home. Ooh, yeah. Yeah, yeah, you feel free. Doesn't need to be the whole. What you need, what you need to feel alright. What you need, what you need, what you need to feel alright. What you need, what you need. Oh, you gotta see, come along. So give a little bit, give a little bit of your love to me. Give a little bit, give a little bit of my life for you. Now's the time that we need to share. Don't send a smile. We're on our way back home. What you need, what you need, what you need, yeah, come along. What you need, what you need, what you need to feel right. What you need, what you need, what you need to feel at home. What you need, what you need, what you need to come along. Such an alright, come along. Sing it tonight. But I was sitting, waiting, wishing you believed in superstitions. Then maybe you'd see the signs. Lord knows that this world is cruel, and I ain't the Lord, no, just a fool, and a loving somebody don't make them love you. Must I always be waiting, waiting on you? Must I always be playing, playing your fool? I sang your songs, I danced your dance, I gave your friends all a chance. Putting up with them wasn't worth never having you. Oh, maybe you've been through this before, but it's my first time, so please ignore the next few lines, cause they're directed at you. I can't always be waiting, waiting on you. I can't always be playing, playing your fool. I keep playing your part, but it's not my scene. Want this plot to twist, I've had enough mystery. Keep building it up, but then you're shooting me down. But I'm already down, just wait a minute. Just sit and wait it. Just wait a minute. Just sit and wait it. But if I was in your position, I'd put down all my ammunition. I'd wonder why it taken me so long. But Lord knows that I'm not you. And if I was, I wouldn't be so cruel. Cause waiting on love ain't so easy to do. Must I always be waiting?
All right, good morning, everyone. How are we doing today? Kind of all over the place. All right. So let's see where we're at. Good number. All your grades are updated. So those were all released to you guys. This week, hopefully you saw the announcement with the week 5 assignment. Please read the instructions carefully. You still need to take a screenshot of your score. You still need to submit it, but it's not an ATI, it's that document that I posted. So please make sure that you review that. Also this week you have your disease PowerPoint due. So that being said, I don't know if you guys have ever tried to do references in a PowerPoint, but it doesn't work too well. So don't fight with the hanging indent, okay? It won't let you do a hanging indent. Don't stress out about it. As long as it is formatted correctly, commas, periods, the right things are italicized, all that jazz, you're fine. So just don't stress yourself out about it, because I know it can definitely be extremely frustrating. Yeah. What else? Questions about the PowerPoint? Nothing? Man, okay. Hopefully you guys saw too that there'll be a key concepts review tonight at 7:30. I was gonna do 7, but I have to pick my daughter up and I wanted to give myself enough travel time so I wasn't late and then you guys freak out. So we'll start at 7:30. Come prepare with any questions and to participate and kind of just go over stuff. It'll be set up a lot like the last time with some Jeopardy questions and then just expunging on the conversation, and diving in from there, which I think is probably the least painful way to do it without, having to overthink things. So 7:30 tonight. It's not the Zoom for class, it's a different Zoom. So make sure you use the one that's on the announcement. Because when I create the ones for class, it creates a different room. It's not my personal Zoom, so I don't know. At any rate, it's there. If you need to set up office hours with me to review things, shoot me a message, and I'll do my best to squeeze you in. The goal is to get you in before the next exam, because if you got to fix something, you kind of need it before the next exam. So yeah, just shoot me a message and we'll see what we can do. Anything else? All right then. So
I do have a question about the PowerPoint thing. It said to reference pictures. If we're using the insert ones from like the clipboard or whatever is on PowerPoint, do we have to reference those?
I don't think so, because that's like standardized clip art that's available to anyone.
Okay.
I wouldn't take off of that. If it's something from like Mayo, then yeah, but not from clip art. That's a good question. All right. Well, then we're going to dive into today's activities. So today we are doing probably, I think it's the most fun. I love cardiac rhythms. I think it's a fun little puzzle to kind of figure out what's going on. So that's what we're going to dive into. Hopefully you took a listen and you have a good understanding of things from the get-go. What we're going to do is going to do a brief review, about 45 minutes or so. So if there's questions, you can ask. I'm going to hit some key points. We're going to skip some things because we're going to do activities with them. So hopefully you don't get too overwhelmed. You probably will, but we'll try to fix it as best we can. So, all right. So let me load this on up here and we will rock and roll then and cruise right along. All right. So this week is called EKGs, but it's pretty much cardiac rhythms. Okay. So the key to identifying cardiac rhythms is first understanding what its parts are. And it is literally 5 letters: P, QRS, and T. Yes, there are U waves. We're not getting into them. You'll never see them. Don't worry about it. So don't stress out about the U wave. I think you'll see them like once in your entire career. So if we can understand what's going on with all these wiggles and jiggles, we're going to be okay. So first and foremost, all an EKG or a rhythm strip is tracing the electricity in the heart. So remember, we have our SA to our AV, bundle of His, left and right bundle branches, Purkinje fibers, and myocardium. That's that pathway. When something goes wrong with that electricity, that's when we kind of get to see some of those wonky rhythms where you're like, oh, this is not normal. So with an EKG, first and foremost, ECG, EKG, same exact thing. Canadians use ECG, and I think Europe does too. We use EKG. It's what I was taught, so I default to EKG. They're both the same. We're looking at the pieces of it and looking at the heart rate and the heart rhythm. Okay, we're just looking at the electricity. That's all that little squigglies are. So when we are dealing with dysrhythmias, first and foremost, you need to understand that we have to treat the patient and not the monitor. What do I mean by that?
Look at the symptoms the patient is experiencing and treat that.
I think your microphone is covered.
Sorry, I said, look at the symptoms that the patient's experiencing and treat that.
Okay, so why would we do that? If the rhythm says that they're like flatlined and there's no heartbeat.
I mean, sometimes the monitor can say something and the patient can show a different thing. Sometimes it's just the monitor that is not well connected. So make sure that you are actually reading the symptoms and everything and not just the monitor.
Yeah. We all know how difficult and frustrating technology can be, right? We think that something's going to work and it's going to do the right thing. And then it's just like, haha, not today. But those little leads can come attached. People can move, and all of a sudden it looks like your patient's having VTAC. They're not, they're moving. So we have to make sure we're looking at our patient. Are they awake? What's going on with them? The worst thing you could possibly do is be like, oh my God, this person doesn't have a heartbeat. Let me start CPR. And they're just sleeping. So we have to make sure that we're looking at them. It sounds really basic, but you would not believe the amount of times that we panic when we see something like that right in front of us, you know? Or if you've ever been on a telly floor where the telly is going, you'll hear the boop, 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 boop. And your instinct is like, oh crap, what's going on? And it's really nothing. So we have to make sure we're just looking at them. We're going to get into rhythms. And one of the things that we have to also understand is just because there's electricity in the heart doesn't mean that there's a heartbeat. So we have rhythms where there'll be electricity, but the heart won't beat. Or if somebody has a pacemaker, that pacemaker is still going to provide electricity, but the heart itself is not beating. So that's a little side note. Last week, we talked about signs and symptoms of cardiac output. They are need to know. You have to be able to look at your patient and be like, okay, this is going on. I wonder what's going on with their heart. This looks like they're not perfusing well. So a change in their level of consciousness, if they start getting real sleepy and kind of out of it, low blood pressure, high heart rate, cold, pale extremities, they're not perfusing, low urine output, and dizziness. Need to know. These you should be like, okay. Or if you have to do teaching about decreased cardiac output, these are things that you would want to share. Circle, highlight, make a note. This will not go away throughout this entire semester. Even when we start talking about feet, we need to know about decreased cardiac output. So the setup, this says 3-lead ER, we do 5. So 3 leads, they exist, they're there. But when we do 5 leads, no matter what, they're always the same. White on the right, snow over grass, smoke over fire, brown in the middle. Doesn't matter what hospital, what city, what state, what's going on, this is universal, okay? So this doesn't matter if they are in a hardwired machine in the room, like in an ICU or the ER, if they have a little portable monitor in a med-surg floor, or if they go home with that Holter monitor, that's how those leads are going to be placed. If your patient needs an EKG, a 12 lead, these 5 stay in the exact same spot, but we add 5 more. And they're basically going to go around the heart. So it will go around here. So it says that it's 12 leads. Technically it's 10 stickers, but it's monitoring 12 different pathways. Okay, so don't get tripped up when you like see this and you're like, but I'm looking for 12 wires, I only have 10. 10 is correct, but we're looking at 12 pathways. There are something called a posterior EKG or EKGs that they'll do on children, and these will be specific to certain conditions that they were looking for. If they're looking for a posterior MI, they are not something we do very frequently, but they do exist, and they'll just go on the back. So they'll have some stuff in the front, but then they'll get a couple of leads put on the back of them. Typically, the EKG techs are the ones that will do this, but they do exist. Are any of you guys teletechs? Or know what a teletech is?
Aren't they the ones that watch the monitors in like the ICU or from the med-surg floor if someone's being monitored continuously?
Yeah.
Can you hear me better now?
Yes.
Okay.
Yeah, that's exactly what they do. They sit there like this guy is doing, and they stare at cardiac strips all day. So if something goes on, they can notify the nurse, because we can't watch that monitor 24/7, right? We have patients that we have to do things for. They do. So if all of a sudden, like this little box is yellow, so and it looks like it's also red, so that patient looks like they might be in like a tachycardic rhythm of some sort, he would get on the phone with that nurse and say, hey, your guy is having this run of VTAC, or this is what's going on. And it lets the nurse know, because we might not otherwise know if we're in a room or doing something else. So that's what they do. This is an example of an EKG, the actual printout. You guys have probably seen the cardiac strips that you would print on a unit, which are great. And then Holter monitors we got here. So that's what we got for cardiac monitoring. Oh, that is awesome, Crystalline. All right, I don't have polling questions today. Sorry, don't have time. So, physiology of the heart. I'm going to go through this really brief because there's a lot of words on here that are just like, whoa, this is intense, right? When we're talking about what we're looking at for electricity, we're looking at the heart squeezing and refilling, okay? So depolarization is the heart squeezing. It contracted. Repolarization is it filling back up, okay? So when we're looking at the heart as a whole, its job is to squeeze, refill, right? And pump it out to wherever it needs to go. So we'll talk about things like depolarization. That's the firing to make everything squeeze. And then we have some issues where sometimes something might fire outside of the time frame. It's off beat. That's where we get things like those dysrhythmias. So it all has to do with the electricity. But this has, again, a lot of words that are kind of like, whoa. Your focus is to know that it's going to depolarize, contract, and then it's going to repolarize when it refills, okay? We care very, very much, though, about the electrolytes with the heart. The heart is very sensitive to potassium, sodium, magnesium, and calcium. So if there is an issue with the heart where all of a sudden we're getting funky rhythms, rest assured, we're looking at those electrolytes. That's part of that, okay? It all has to do with sodium ion pumps, calcium channel pumps, all that good stuff that you kind of want to forget because it was probably a lot, but we look at those numbers significantly with the heart. So if we're concerned about a dysrhythmia, you can expect that these labs are going to be drawn. All right. So here is an EKG. You won't ever have to analyze these. You can look at them and be like, okay, this is what's going on. So real briefly, these first couple leads, these are what we call limb leads. That's your arms and your legs, okay? Then we have your chest leads, which are the ones that are going to be underneath the heart. And then at the bottom, we have the rhythm strips, which are the same as the ones that you would print out on a floor, okay? Now you'll notice sometimes they're upside down, sometimes they're right side up. That all has to do with just connectivity, and it's supposed to be that way. So you don't have to freak out too much. But when cardiologists or providers are looking at this, they're looking at all the leads and all the rhythms, whereas we typically just look at like the rhythm, okay? Because sometimes we can see things in one limb that we don't see somewhere else. So then we need to work it up a little bit more. All right. So let's talk letters. Your P wave, that is your first lumpy bump. This is the atria contracting. When it contracts, it depolarizes. So contraction equals depolarization. Okay, those words are interchangeable. They're happening at the same time. The QRS complex is the ventricle contracting and depolarizing. At the same time, never mind. So P wave is the atria contracting, the QRS is the ventricle contracting, and then our T wave, which is our last little bumpy bump, is the ventricle relaxing. It's refilling. We don't see the atria repolarize or relax or whatnot. It's absorbed within the QRS. So it happens at the same time, if that kind of makes sense. It doesn't have its own little lumpy bump. So we have our P wave, which is our atria contracting, our QRS, which is our ventricle contracting, and then our T wave, the ventricle is relaxing and refilling. Simple enough, but that's what those all mean. And that's it. Feel good about that?
I have a question. I know you're going to go over this, but it just dawned on me. So when you have AFib, there's a problem with the atrial part of it, and it's going to show up on the P wave, right? Okay.
So when we go into rhythm strips, your P wave is your atria contracting, right? With AFib on a rhythm, we're going to have way too many P waves that make no sense because it's going like this. So we're going to have a lot of squiggly lines.
Cool.
Okay, so the rate. One of the big things that we have to do when we're determining what's going on with a heart rhythm is what is a heart rate, okay? Because we know normal heart rate is what?
60 to 100.
60 to 100. If it's less than 60, we're Brady. If we are higher than 100, we're tachycardic. And so that's why we need to know this when we're identifying our rhythm, because certain rhythms will have really high heart rates and certain rhythms will have really low heart rates. So the easiest, most simple way to calculate your rhythm is to count your QRSs. So you'll count your R wave. Now, first and foremost, this is a 6-second strip. The reason why I know this is a 6-second strip is because these little black notches up at the top, from notch to notch is 3 seconds. Okay, so that's how I can identify what my heart rate is going to be. So in 6 seconds, I have 7 QRSs. So I'd multiply by 10. 7 times 10 is 70. I have a heart rate of 70. That's all you have to do if you know that you have a 6-second strip. You will always get 6-second strips too, unless, if we're trying to have you do something. So count your times within 6 seconds, multiple by 10. Not hard. There is another method that they use. It's a formula. It's about memorization. It goes down in groups. I don't like this. This makes no sense to me. I don't teach it because you guys need to memorize more things like a hole in the head. Count your QRSs. That's the gold standard. You can also divide the number of QRSs. You have to divide the boxes between the QRSs. So if you have 5 big boxes, which we didn't get to, that's 25. So you could divide 1500 by 25. It makes more sense in a few minutes. Counting your QRSs in 6 seconds is obviously the easiest way. We can jump back to this later. Okay, so let's get into the EKG basics. Okay, so first and foremost, let's look at this. I'm gonna try to blow this up as best as I can. I know it's difficult to see. Okay, so where's my little laser pointer? It ran away. Uh-oh, because it's not letting me do a laser pointer and a magnifying glass at the same time. All right, do you guys see this bigger pink box, this thicker line? Okay, this big box, they go 5 by 5. There's 5 little boxes going across and 5 little boxes going down, okay? This big box is 0.2 seconds. The little box inside of there is 0.04. So 5 of these big boxes is 1 second. So the very, very small ones, again, is 0.04. The whole box is 0.2. And then 5 of these big ones is 1 second. So if you really think about it, when we start measuring things, how quickly a heart beats or how quickly an atria beats, it's like half a second, which is really crazy to think about. So this timing is important, okay? This is how we measure things. Timing is important because it's telling us what's going on with that electricity, okay? So, I'm gonna fast forward a second, we can come back, all right? So, this is a very ugly, drawn out, spread out QRS complex, okay? So P wave. Our P wave is that SA node firing, and it's going to depolarize both of the atrias. Both atrias squeeze at the same time, okay? That's what that P wave means. Your PR interval. This is the atria firing down to the ventricles beginning, okay? So we're looking at this, the reason why, so the PR interval is important when we're determining heart blocks. Heart blocks are when electricity is not getting all the way through. So with heart blocks, we typically have issues with our PR interval, okay? And our PR interval is going to be from the start of the P wave to the start of the QRS, okay? If we are to measure a P wave just by itself, it should be 0.06 to 0.12 seconds. That's how long it takes the atria to squeeze. The PR interval, atria squeezing to the start of the ventricles, that should be 0.12 to 0.20. Anything more than 0.20 tells us we have a heart block going on. Okay.
Do we need to know these seconds?
Yes, because when we start talking about heart blocks, This is like the key characteristic to understanding it.
Do you mind going over those seconds just one more time?
The PR interval?
Yeah.
Okay, so the PR interval is from the start of the P wave to the start of the QRS. So the electricity of the ventricle or the atria squeezing, triggering down to go to the ventricle, because the QRS is when the ventricle is going to depolarize. We use this to determine heart blocks. This interval should be 0.12 to 0.20, which is going to be like three small boxes, one big box, less than one big box.
Thank you.
The QRS complex, this is going to be your ventricle depolarizing. When we look at QRS complexes, we're going to measure it, and it's typically very, very narrow. Like that is more of what a QRS complex looks like. This one's really blown up. We're going to look at it to determine, is it wide? Because if it's wide, that's an issue. Or is it oddly shaped? So this is telling us about the ventricles. So your most important things really truly are your P waves, your PR interval, and your QRSs. We do look at the ST segment, especially when we're looking at MIs. So the ST segment is basically from the S to the start of the T wave. So when we talk about ST elevation, this segment is way, way higher than it should be. Or ST depression, it's going to be way lower than it should be. So do we always look at STs? Really only if we're concerned about it looking like a heart attack. Your T wave, again, that's that ventricle refilling. We also have something called a QT interval. And basically what that is we're looking from the Q all the way to the end of the T wave. This is telling us how much time it takes for the ventricle to squeeze and refill. We care about a QT interval most commonly with certain medications. So if you guys heard like has a prolonged QT interval, that's what they're talking about, how long it takes the ventricles to fire and refill. Ondansetron, Zofran can cause a long QT interval. So we would look potentially at that. So is it something we look at all the time? Not always. As nurses, we care most about PR intervals, and looking at our QRSs for the most part. So most common things you're going to need to know are these first three numbers. Okay, your P, your PR interval, and your QRS. All right, so we have 5 steps to identifying the rhythm. Okay, so my first step, 1, what is the heart rate? So I calculate that first. Okay, I look at my 6-second strip, I multiply by 10. My QRS is by 10. 2, is my rhythm regular? Well, how can I determine that? When I look at a strip like this, I go to my top, my R, and I take a little piece of paper, if I don't have my little calipers, and I put a line on it. And then I make it long enough so it reaches out to my other QRS. And then I just move it to see if it's even down the paper. Okay, so this to this, and then I move it down. Is this the same? Is this the same? So is it even? Because if it's even, I have a regular rhythm. Perfect. Next thing that I look at is, are there P waves? And so I'm looking at the P waves. Are they there? And do I have a P wave before every QRS? Okay. Sometimes I have a bunch and sometimes I have none. That's going to help me figure out what rhythm I have. It's like a puzzle. The next thing that I'm going to look at is what is my PR interval? So I'm going to measure from the start of the P wave to the start of the QRS. And I get my first PR interval. You don't just look at one PQRST. You have to look at the entire strip. So I'm going to measure my PR interval in my first one, then on my next one, then on my next one, because certain heart blocks will have different things going on. And then the last thing I look at are my QRSs. Okay. I look to see, is it too big? Do they look the same? Is there a QRS after every P wave? Okay. So I'm going to repeat this. 1, what is my heart rate? 2, is the rhythm regular? Do my R's march out nicely down the strip? 3, P waves. Do I have them before every QRS? 4, my PR interval. What is it? How long is it? Is it the same throughout the strip? And then 5, my QRS complex. What does it look like? Is it the same? Is there one for every P wave? Those are the 5 steps to identifying rhythms. Cool? Okay. All right, so I'm going to do this very, very briefly. I'm actually not going to go into rhythms, but I'm going to ease your mind a little bit. We do not cover junctional rhythms, so you can cross that off your list. Okay, so no junctional rhythms. We also don't do idioventricular rhythms, but we're going to do the rest. It'll make sense, I promise. Okay, so I'm actually going to skip all the rhythms for right now. We're going to get back to that. Okay. Okay. So remember last week, 2 weeks ago with MIs, we talked about what an MI can look like on an EKG. And it probably made a whole lot of sense. You know the words, but you don't always understand like what that actually means. So one of the things that we can see are hypertrophic T waves with an MI. And what does that look like? Our T wave is a big old loop-de-loop. I mean, it's bigger than our QRS. So it's big and wonky. This could be an indication that an MI is going on. The second thing is ST elevation. So every strip has an isometric line. It's that straight line that they kind of all either rise above or go below. So with ST elevation, the ST segment is way above that isometric line. Okay, so this is what the isometric line should be. Our ST segment is way up high. That's not a good thing. That's a STEMI, ST elevation MI. The other one is going to be ST depression. So the ST segment is below that isometric line. That's an NSTEMI. And then we have the T wave inversion. So instead of being up, it's down. P waves could be upside down because of lead placement, but when T waves are upside down, that's an issue. So those are the 4 possible EKG possibilities, which I know you guys remember, but this is what they actually look like. So hopefully that kind of solidifies things a little bit. Okay. So let's talk about management. Okay. Give me 1 second. We'll talk about management. Okay. So CPR. When do we do CPR?
When there's no rhythm.
Okay. So with CPR, they have to have no carotid pulse and no breath sounds. Okay. We have to check that before we get that going. The whole goal of CPR is to reestablish circulation and to prevent brain damage. Anoxic means without oxygen. So an anoxic brain injury means the brain did not get oxygen for an extended period of time, and that can cause somebody to be kind of comatose or in a vegetative state. So the whole goal is to get things going again, okay? We have to make sure that we check that they have a pulse and they're not just really deeply sleeping, and we start CPR. We typically do not stop CPR until the patient has been declared deceased, or if we get the heart rate back. That's that return of spontaneous circulation, ROSC. That is the goal. Has anyone done CPR on an actual person? How'd that go?
I've
A lot of work.
A lot of work.
I've actually had to give CPR on multiple people. It's really odd. I had to give the last one. It was a lady at Ross. She just dropped on the ground, and it was really. I get really emotional every time, and so after I'm just usually crying. But it's a lot of work, and you always just feel like your whole body is moving everywhere, and yeah.
It is incredibly emotional, and that was okay to have those emotions and take time out. And it's really complicated when you have to do it in a room, and then, you know, a few minutes later you have to go into another patient's room who's yelling at you for a turkey sandwich. So you're entitled to be upset and to take time and to recoup. But if you have not done it, it's incredibly exhausting. It's like leg day on your entire body. You feel it for days afterwards, and it's incredibly violent. It is extremely violent, especially if we start getting into things like the ribs fracturing. So I don't think a lot of people realize the bad things that can happen from CPR, especially with some of our older patients. And they think that great grandma's going to live forever, and they want them to have CPR, and then we break every rib in their chest and recovering from that. And it's ugly, and it's bad stuff can happen. So with CPR, we can fracture their ribs, which can puncture their lung, which can puncture their liver. And then with CPR, when we are actually compressing, air is forced into their abdomen. So you can see their abdomen will completely like bloat out very far as you're you're pumping air into their, by compressing on the heart. So it is a flawed process in the sense that we're human and it's exhausting. And the first few pumps that you give might be great, and then it can decrease, you know, as you're trying and exhausting and exerting yourself. So things like the machines can be very helpful in preventing those things from happening. They do have, certain municipalities have these CPR machines that will do the compressions for you, which are pretty phenomenal and will guarantee great compressions every single time. And it takes out that human exhaustion element. So CPR is not always effective. I think the number is quite low actually for people that have survived CPR. So so this is not the most up-to-date CPR procedure. We don't care as much about the breathing anymore as we do about returning that circulation. So make sure that you are just following your BLS protocol, which is usually 2 minutes of CPR, and going from there. But we have to identify them as unresponsive. We have to call for help. That part has not changed. And we go until stuff comes back or time of death is called. Alrighty, so one of the most difficult concepts that students tend to have is the difference between cardioversion and defibrillation, because both shock you. Okay, they're both electric. Cardioversion is a timed, synchronized shock to help get a patient out of a certain rhythm. These patients have a pulse. That's a big thing. They have a pulse. and they're medicated. We give them a little milk of amnesia to kind of like chill them out, and then they shock them to get them into a more normal rhythm. So they're alive, they're awake, they have a pulse. We're getting them out of something that they shouldn't be in. We could do this with an atrial fibrillation patient. AFib doesn't, it's not the worst thing in the world. It's not the best, but it's not the worst. You can live with it, but we can potentially shock you out of it by cardioversion. The big thing with cardioversion that we have to watch out for is if a shock were to be delivered on the T wave. Now the T wave is when the ventricle is repolarizing, it's refilling. So if we shock when that happens, it can cause the ventricle, we can go into VFib or VTAC, sorry, VTAC. There's a kind of VTAC we don't go into called torsades, which is actually a really pretty VTAC. I know that sounds really odd, but it kind of looks like ribbons or like a helix, like a DNA helix, like on its side. So it's like real big and then goes real small and real big and then real small. It's cool looking. Obviously, it's not the greatest rhythm, but it looks pretty. So that can happen if we shock on the T wave. We do typically want them NPO before we're going to do this, but again, they have a pulse. It's a timed, synchronized shock. Okay. Defibrillation is used with VFib and pulseless VTAC. These are two rhythms that are not compatible with life. They do not have a pulse. They are not conscious. This is an emergency, so it's different than cardioversion that way. We still yell clear, we shock, we do CPR with this, okay? So with cardioversion, they're awake and sedated, they're on a monitor, all that good stuff. But with defib, it's an emergency, they don't have a pulse, there's no output, they're unconscious, we're trying to save their life. And it's used in conjunction with CPR. Cardioversion is not. Cool? All right, so let's
Well,
talk
I was
about
just
case-
wondering,
oh, yeah.
when their heart is not, so there's no pulse, there's no nothing, is the heart just flooding with blood and then it's like going back into the lungs? Is that what's happening, or?
Kind of like a standstill because nothing's really moving anywhere. So you're not having pulses going throughout the body. Nothing really can move because the
Okay.
heart, especially with like VFib, it's just shaking. It won't contract. And with VTAC, the heart is, there's electricity and stuff going on, but it's not pumping because we have no output because there's no pulse if it's a pulseless VTAC. So yeah,
Okay.
it just kind of sits there.
We had a patient who we were going to cardio invert. Her pulse was like 219. And I didn't realize at the time how bad it was. I mean, I knew it was not a good pulse, but I didn't realize how bad it was. And so everybody came running and they were getting ready to cardio invert her. And I was excited to watch it. But then when they had to do something, I think they were giving her a new IV. And when they were doing that, something happened that completely switched her pulse right back to normal. And I can't remember what they called it. It like she was like shocked, or not like shocked, but like scared into having her pulse, but they called it something and I can't remember what they called it.
When people have like that high heart rate, one of the things that we have them do is bear down.
Maybe
So-
that's,
We do a vagal maneuver, so they can either breathe into a straw or we have them bear down because that can help decrease the parasympathetic nervous system. Yeah, so we'll have them kind of just poop but not poop, and that can help with that. It doesn't always, but it is the first thing we do because it's the least invasive. So yeah, we typically try to bear down. We can try medications, and then worst case scenarios, we can cardiovert. And sometimes they will snap out of it on their own. Their heart gets like its common sense back and it's like, okay, yep, this is how I go, not like this. Or on the flip side, when the heart's going that fast for a long period of time, it can poop out on you. And then you can end up with an even worse rhythm, like a VFib. So yeah, she might have gotten herself out of it. I had a patient who carried a straw in her purse because she would have runs of tachycardia. And by blowing on the straw, it would help her get back into a normal rhythm. So it's awesome that you got to be part of that and watch everything happen. Okay, so pacemakers, we have two kinds. We have a temporary and we have a permanent. A temporary pacemaker we put on the outside of the body, and basically it's going to provide a little bit of stimulation to keep the heart pumping. And this we can use in emergency situations, most typically with our heart blocks or really symptomatic bradycardia. Permanent ones are for chronic dysrhythmias that are implanted underneath the skin that can either pace the atria, the ventricle, or both. Okay, so this person, this little line is what we call a pacer spike. Okay, this little pacer spike is happening before the QRS. So any guesses as to what kind of pacer this is? Because the QRS is what?
It's a permanent one?
We can't tell if it's permanent, but
A
if it's
ventricle,
like-
it's for the
if-
atria
yeah, is this a ventricle or an atria?
and atria.
It's right before the QRS. So it's telling
Oh,
you
the ventricle, because the ventricle's not going to contract.
right. So the
Okay.
QRS is when the ventricle contracts. So if the spike is right before the QRS, the spike is saying, your turn.
Do this. Okay.
And if it was an atrial pace, the spike would come right before the P wave. And then if it's both, we'll have a spike, P wave, spike, QRS. So that's how we can tell if it's atrial paced, ventricle paced, or both. And typically, for whatever reason, I truly do not know the answer why. So because somebody will ask, with QRSs and pacemakers, the QRS is upside down. I don't know why. So I'm gonna have to Google that because I truly don't know. So with permanent pacemaker placement, oh, that's a lot of P's. Again, we do it for symptomatic bradycardia, so a heart rate less than 60, or with certain types of heart blocks. So with it, standard surgical potential complications apply: infection, bleeding. We can also cause arrhythmias or the lung to collapse. So beforehand, they're going to be educated on what the pacemaker does and what they're going to have to do afterwards, and the big bad scary things to look out for afterwards. After the pacemaker is placed, and this is a pretty quick procedure, the pacemaker gets inserted underneath the skin, the wire goes into the vasculature down into the heart. Okay, so this is a ventricular paced one, it ends in the ventricle, atrial would end there, and then if it's AV paced, there might be two wires, it really depends. So afterwards, we're looking at their heart rate and their rhythm. Shocker, they just had something done with their heart. That makes sense, right? We're watching for sedative effects from the analgesia that they had. They also, this is important, we keep their shoulder in a sling. We don't want them moving that arm, okay? Nothing above their head, no golfing, no baseball practice. We minimize movement for at least a week. And usually it's a lot longer. We're watching for bleeding and infection. We also need to assess for the hiccups. Of all things to watch for, why would be assessing for hiccups?
Could that indicate it's not working properly?
Or it's in the wrong spot, or something is tickling the vagus nerve or the diaphragm, causing the hiccups to occur. So hiccups with a pacemaker consistently won't go away, could mean something is wrong with the pacemaker, which I think is really funny. That's one of those complications I never forget because it's cute. I don't know. hiccups suck, but. So education. Everybody who has a pacemaker needs to carry their ID card. There's tons of different models, makes, all that stuff. So if something happens and they need to get help, that information is accessible to healthcare people right away. We don't have to do deep sea diving to figure it out and waste time. So they should always carry their card. Those signs of decreased cardiac output, patients need to know those. The dizziness, the lightheadedness, the decreased pulses, all that. Activity restrictions for at least 2 months. No direct blows. We want to avoid magnets, no magnets over a pacemaker. And they need to let security know anytime they go through anything with one of those wands that they have a pacemaker, because we don't want to deactivate it. Somebody who has a pacemaker will fire even after they're deceased. So the heart isn't beating, but electricity is still going to be popping up. We actually have to demagnetize it to shut it off, because on a monitor, it looks like they're almost still alive, but they're not. No magnets, no magnets, no magnets. Okay. On the flip side, we have something called an ICD. This is an implantable defibrillator. It will shock a person back into a normal rhythm. So with an ICD, it will shock someone if they go into VTAC or into VFib. Okay. So it detects that, oh, okay, my heart's doing something crazy, and it'll give them a little buzz. This isn't something that's going to like throw them on their butts, but if you've ever like licked a 9-volt battery or like gotten a shock when you plug something into the wall where you're just like, ooh, that's kind of what happens with them. They definitely know that it happens, but it's not something to like make them bawl like a baby or whatnot. So whenever an ICD fires, they need to go to the hospital to be evaluated. Non-negotiable, huge teaching point. If it fires, you need to go. We want to prevent infection. Again, it's going to be implanted similar to a pacemaker. So we have pacemakers, which will make the heart pump, tell it to go. We have ICDs that will shock you because something happened. We also have pacemakers that are ICDs. So it will pace and then fire if it needs to. So lots of different things. Everything has its own job. Okay. All right. We will go into medications after the first activity. So questions so far? No? All right. This is a lot. I know it's a lot. We got this. Okay. So let's go ahead here, take our first break, and we'll come back and we're going to do our first activity. So we are at 10:55. Come back at 11:05. Please and thank you.
yourself somewhere out there. Did you get to be a star? Don't it make you sad to know that life is more than who we are? Grew up way too fast, now there's nothing to believe. Reruns all become our history. A tired song keeps playing on a tired radio. And I won't tell no one your name. I won't tell your name. Think about all the time that I don't need to sing. It's lonely where you are. Come back down. I won't tell your name. There's a place I dream about where the sun never goes out and the sky is deep and blue. Won't you take me there with you? Oh, I can take you again. Shade our skin, let the sun shine in. At the edge of the ocean, we can start over again. There's a world I've always known, somewhere far away from home. When I close my eyes, I see all the space and mystery. Oh, I can take you again. Share our skin, let the sun shine in. At the edge of the ocean, we can start over again.
Okie dokie. All right, we can bring it on back here. So, all right, our next activity is going to be done in groups. Hate to break it to you, I'm sorry. You have to work together as nurses, so here we go. One of the biggest barriers I think that nursing students and novice nurses have is teaching, okay? So this next activity, I'm going to break you guys into groups, and each group will be assigned a rhythm, okay? In this chart where your rhythm is, you're going to explain the defining characteristics of the rhythm. So what does it mean? What does it look like? P-wave situation, QRS stuff situation. Then the next column, you're going to list the causes of your rhythm, you know, whatever reason that may be, how we treat it, and then nursing considerations. What are things that you would want to know, that you would want to teach? When we're done, you guys will have one massive study guide with all your rhythms, all the stuff you're going to need. So put the information that you would really truly want to know about your rhythm, okay? The weird thing, the weird treatment, nursing interventions, positioning, teaching, all that kind of stuff. So you'll do this in your groups. There'll be about like 3 to 4 people in each group. And then when we get back, we'll present it and you guys will teach everyone else about your rhythm. So in front of every rhythm is a number. When I divide you into your breakout room, if you're in breakout room number 4, you're doing PEA. If you're in group number 6, you're doing PVCs and PVAs or PACs. Okay, so that's how you know which rhythm you're doing. Sound simple enough?
I'm sorry, I may have missed it. Where do we find this worksheet?
I'm going to share it in the chat right
Oh,
now.
okay, okay. Thank you.
So I'm going to share it with you guys. You have to be logged into your Joyce though. So if there's an issue, you might have to send me a request like, can I access it or whatever, or if there's a problem. As long as one person in your group can edit, I will also post the finished copy later on this week when it's all done. So you'll get it no matter what. I'm a big proponent of like, let's create stuff in all one place. And this chart kind of does that. So painless enough, right?
I have a question. We don't have to submit this, right?
No. But you have to fill it out and present it in class with whatever rhythm you have. You're going to teach us all about VTAC. All right, so we have 13 rhythms, so there'll be about 2 to 3 people per group. Okay. If you are having an issue with anybody in their group not pulling their weight, which I know you won't because you guys will all want to help each other, let me know. There's a help button in the breakout room. So if you need me, I can come running. But what else is there? Oh, and if you choose not to go to your breakout rooms, you will be removed from class. So if you're like you have to click accept. If you just sit there and don't go, you're not helping us. So peace out.
To help us get the information, we can just use the PowerPoint or our ATI book.
Yes, PowerPoint, ATI, your textbook. Oh, one thing that I forgot to mention. You need to include a picture of your rhythm, but not a picture that's in your PowerPoint. Find me a different one because those can be harder to read. And I know one of you guys is driving, so hopefully we can work Mara around that. So we can work with that. Yeah, picture, not from the PowerPoint, but your information can be from there. Some of it. There's a lot more about some of these rhythms that are just on the PowerPoint. Is kind of what I'm getting to. So. Okay, so I see a bunch of you already in the document. Fantastic. I'm going to check my email because I saw an alert for a request. So I'm going to split you up now. Good to go? 1, 2, 3. All right. Looks like 3, 3, 3, 3, 3. Room 13, you only have 2. So just so you know. Hopefully that works out okay. If not, let me know.
the atmosphere, the clouds of Jupiter in her head. Yeah, it's not summer and it's not rain. Mom, that there's time to change it. Time to stay on the move. It's like spring, talk like too late. Even when I know you're wrong, and you imagine your first dance, please, that romance, loud, long conversation. That's all nothing that you ever had in me. Tell me, if you finally get the chance to dance alone, a lot of days. Yeah, that's all the Milky Way. do those things to you.
Oh. Okay. Everybody should be back. Just a second here, so that's great. Hopefully not too painful for you guys. Looks good. How are we feeling? Okay. Come on. Let me get this last few things out. All right. We're all back. We're all back. Okay, here we go. So hopefully you feel pretty comfortable with your rhythm. We're going to go through and go over them all. And basically you guys will present the information to all of us and I will fill in some gaps. So if there are any, I don't expect there'll be too many, but you know, that's how we do. So we will kick it off with, well, let me explain something real quick first. Okay, so normal sinus rhythm. That is the rhythm that we are all in. Okay, well, I can't say we all. That's what we want to be in. Okay, so what normal sinus means is that we have a heart rate of 60 to 100. It is regular, so it's not irregular heartbeat. We have a P wave before every QRS. the PR interval is 0.12 to 0.20. And our QRS is less than 0.12. So it's only like 2 or 3 small little boxes. Nice how it's going to be. There is no treatment for it because that's what we want to be in. So there really aren't any nursing considerations with this. But when we talk about sinus, normal sinus rhythm, sinus Brady, sinus tachycardia, that sinus truly means regular heartbeat. The only thing off between Brady and tachy is going to be the level of heart rate. Brady being slow, tachy being high. So sinus Brady, I didn't have anybody do because it's kind of a boring one, but fill it in as needed. We really typically don't do anything for sinus Brady unless the patient is symptomatic. So if they're having signs of decreased cardiac output, low blood pressure, a change in their level of consciousness, if it's causing issues, they will give them medications like dopamine or some kind of pressor to help raise everything. Some people live in Brady land, okay, less than 60. It is not uncommon for elite athletes to have a resting heart rate in the high 40s, low 50s. As long as they're not symptomatic, not a problem. So, all right, who is my sinus TAC group? You're going to be first.
That was us.
All right, go ahead.
So to describe sinus tachycardia, it's just when the SA node sends electrical impulses quicker. It's fast and steady, and it's just a normal sinus rhythm, but it's just fast. The heart rate is more than 100 to 150 beats per minute. It's a regular rhythm. There are P waves before each QRS, and they're identical and separate from T waves. The PR interval is 0.12 to 0.20 seconds, and then QRS is also less than 0.12. Causes, we have just exercise, caffeine, anxiety, stress, drugs and alcohol, and some lung conditions. To treat it, we just want to eliminate potential triggers or stimuli, apply cold compresses, and then just coughing is what we found in our book as well. And then for nursing considerations, just a lot of monitoring. So monitor the EKG and vitals. If the tachy does get worse, it can cause pulmonary embolisms or worsen heart problems. And then report abnormal signs to the physician, educate the patient and family on symptoms to report. Also educate the importance of rapidly reducing the heart rate, administering oxygen, monitoring underlying health conditions, and then assessing for signs of decreased cardiac output, hypotension, confusion, loss of consciousness, and shortness of breath. And then teach the patient to avoid their triggers, like avoid smoking, caffeine, and other stimuli. And then I think we have diagnostics down there. Can you put it down a little bit? Thank you. So we just want to watch thyroid levels, ABGs, their blood oxygen, so anemia, EKGs. We want to do a stress test, an echocardiogram, and then just assess the medications that the patient's on.
Okay. So with tachycardia, the key to tachycardia is understanding what can cause it, which is usually some kind of stressor, whether it be mental health with anxiety or fear or drugs and alcohol. Infection can cause tachycardia. If we treat the cause, we can treat the tachycardia, okay? So like she mentioned, we'll monitor this, especially if they're symptomatic, if they're reporting these palpitations, maybe give some oxygen, IV fluids, just addressing the needs of the cause of the tachycardia. And what that looks like is just that. So I'm going to share this with you guys. This webpage is great resource to practice, to just look at things in live time. Now, I'm going to preface this. There are some rhythms on here we don't cover. Don't freak out about them. We don't learn about wandering pacemaker and all that weird stuff. Stick to the ones that we know. So sinus tach, we have a P wave, we have a QRS, we have a T. If we were to measure out our heart rate, then we would have over 100. And this one's tacking along at like 138. So, okay. Questions on sinus tach? All right, let's jump to the next tachycardia and we will go into SVT.
Can I just
Okay.
ask a question?
Oh, yes, absolutely.
When you add stuff like causes, are you gonna type them on to like the final one, or should we add it as you mention it?
Take your own notes. Yeah.
Okay.
Okay, so for supraventricular tachycardia, we have the heart rate sitting between 150 to 250. The rhythm is regular. For P waves, they'll be abnormal before each QRS, and they're going to be really hard to see. The PR interval is unreadable, and then the QRS is less than 0.12. And then for the causes, we have pregnancy, heart disease and heart failure, drug use with like cocaine and methamphetamine, and then alcohol use, excessive caffeine, chronic lung conditions, and then magnesium deficiencies.
Ooh, I like that you included the electrolytes. Sorry. Okay.
Treatments are vagal maneuver, adenosine push, synchronized cardioversion, beta blocker or channel blockers, and electrophysiology studies.
And then some of the nursing considerations is you want to monitor the vital signs and then continuous cardiac monitoring. So like tele, there's unidentified P waves. It has an abrupt onset. And then the book said it could be AFib, A-flutter, and AV NRT, which is atrioventricular nodal reentry tachycardia.
Above your pay grade. So yeah, SVT, most commonly it's going to present itself in bursts, but sometimes your heart just does not flip out of it. So where are we going? A lot different looking than sinus tach because we don't see those P waves. They're technically there, but we can't see them. They get absorbed. So with the sinus tach, you have them, but with SVT, you don't. And the heart rate is typically much higher than just regular sinus tach. The QRS is pretty narrow. So when we talked about the characteristics of that, that's another thing that we would see. With treatment, again, we're going to start low and slow. Let's do a vagal maneuver. If that doesn't work, we can try some medications or synchronized cardioversion, okay? Adenosine, that is your controlled alt delete drug, okay? It restarts everything. It is also one of those medications that makes you poop your pants as a nurse because the heart literally stops for several seconds. And you're like, please start again, please start again, please start again. And it's not until you get your little boop, boop, that you like can relax. So it's a very scary medication to give. And it doesn't always work. So sometimes they'll go to the beta blocker route or cardiovert. We don't want them to be in this rhythm longer than they need to be because we run the risk of not perfusing, decreasing that cardiac output and making them symptomatic, and the heart's going to get tired. So great job with that one. It's kind of a fun rhythm to look at too. I don't know. Some of these, you guys can think I'm weird. They're just pretty. they look cool. So, any questions on SVT? All right. Let's go into probably the most common arrhythmia you will see, and that is going to be atrial fibrillation. So group 1, take it away.
Okay, so heart rate on this one is 350 to 650. The rhythm is irregular. P wave should be fibrillatory, fine to coarse. PR interval is not applicable. The QRS should be less than 1.2. The cause is just those cardiac cells generating more spontaneous electricity. This could be from coronary artery disease, heart attack, just a heart defect that is congenital, heart valve problems, high blood pressure, physical stress, either to surgery, pneumonia, or a previous heart surgery.
And the treatment is a cardioversion scheduled after 6 weeks of Coumadin. Long-term treatments include anticoagulants, anti-arrhythmics like amiodarone, and ablation.
Some of the nursing considerations are monitor changes in CNS. If they're on medications, to advise them to not stop them abruptly, continuous cardiac monitoring, anticoagulant levels checked, monitor for blood clots, signs and symptoms. And if the patient has had an ablation, the management or the care is very similar to cardiac catheterization.
Okay. So what is happening with AFib? So when they're talking about the heart rate of like 350, they're really talking about the atrial heart rate. So typically when we look at a heart rate strip, it's going to be kind of a normal, the ventricle rate is going to be a lot slower. But with AFib, the atria is going all crazy. Okay, so that's why it's so high. But our ventricle rate is going to be like typically a more normal heart rate. Okay, but when we look at it, because the atria is going bananas, we're going to have a crap ton of P waves, and they're not going to make any sense. This is kind of a chaotic rhythm. There's a lot of squiggles, or good squiggle, a lot more squiggles, right? It looks like a kid who's drawing, in all honesty. So again, with this, these people, you can live with AFib and be totally fine, but they should be anticoagulated. So typically they're going to be on your warfarin, your Coumadin. We're checking that PTINR. If they're on a different anticoagulant, if there's something to watch, we watch that. Monitor for bleeding, and dietary changes. All that bleeding stuff has not gone away, and it won't go away this whole semester. But they're at high risk for throwing clots because of the stasis of blood that doesn't fully get pumped out because we don't have enough atrial kick. It's not squeezing, it's fibrillating, it's shaking instead of actually squeezing. So some will get left behind, it will pool, clots will form, it can get dislodged and then make its way right into the lungs, right? Because it goes from the right side of the heart to the lungs, boom, we just created a PE. So we want them coagulated. Yeah, it's very, very squiggly. This will probably be the one that you see the most. If they do need treatment, we can do the ablation, they can do the cardioversion. But when you listen to them, it's kind of interesting to hear it. And this is an irregular rhythm. So if you look at it, our QRSs, they don't march out nice and pretty. They're kind of just all over the place. Okay. Questions on AFib? All right. Let's do atrial flutter. This is my grandma's favorite rhythm. She says it's so pretty. She's a cardiac nurse. This is her favorite. All right. Take it away. Group 7.
So atrial flutter, for the heart rate, we have atrial and ventricular. Atrial is 220 to 430. Ventricular is usually less than 300. The rhythm is regular or variable. P wave is usually sawtoothed appearance. The PR interval, it said it couldn't really measure it. QRS is usually less than 0.12. caused by an abnormal electrical circuit in the atria. There's coronary artery disease, hypertension, heart failure, pulmonary embolism, and cardiomyopathy. Treatments are like calcium channel blockers, antiarrhythmics, anticoagulants, the vagal maneuver, and if they're unstable, then a cardioversion. We weren't sure what to put for nursing interventions, but we did like provide reassurance and emotional support. There are risk for blood clots, so watch for signs of PE. Have emergency equipment available in case of cardioversion, and check anticoagulant levels.
All right, perfect. So yeah, atrial flutter, its characteristic is going to be what they call that sawtooth pattern. So if we look at this, we got a bunch of P waves in between our QRSs, but they're a lot more uniform and make a lot more sense. So with AFib, they were kind of bonkers, but with the flutter, they look nice, neat, and organized. And then this rhythm, our QRSs are pretty regular. So they're a lot more like on path. If you were to march them out, they stay in line. But in between is when you got a whole bunch. And again, they look like the teeth of a saw, you know, something you cut with. This is how we tell them apart. Our interventions are not much different unless, you know, anticoagulate, medications, that sort of thing. Yeah, that's what we got with that one.
I had a question between the two, flutter and fibrillation. So am I understanding this right? Fibrillation, the atria is just kind of like spazzing, like there's no regular like rhyme or reason to it. And with flutter, the atria is still like not contracting properly, but on a more regular rhythm.
Yes. So
Okay.
let me show you something I found that kind of breaks that down a little bit. Shows the difference between the heart rhythm, the way that the heart is actually going. So, oh, hold on. So this is what happens with atrial flutter and with atrial fibrillation. So with flutter, we got impulses, but it's a lot more controlled. With fibrillation, it's kind of bonking out and going everywhere. The electricity is going everywhere. But with flutter, it's still kind of bonkers, but much, much more controlled. AFib has a lot more electrical impulses that are going on, which is what's causing all those extra crazy chaotic P waves and making the ventricles kind of go like not what they should be doing either. All right.
Professor Winsinski, can I just ask, how long do people generally have these how long do they live with these heart conditions? Is this like a couple of years, or could this be 15, 20?
Yeah, it could be a really long time. Like some people with AFib, they choose not to get cardioverted because it's a lot. And if they're not symptomatic and they're not feeling crummy and it's well controlled, if their heart rate is under 100, you can be fine. You just have to make sure you're running the risk of not getting a clot. So some people will flip in and out of AFib. Like all of a sudden they'll be fine, and then they'll get sick or something will happen, and all of a sudden they're in AFib. And then a little while later, they flip back out. So it's just something they'd get in touch with a cardiologist with. We'd watch, we'd monitor. And as long as they're not symptomatic, we'll just continue to monitor and educate them and make sure that they know, like, if any of this stuff happens, you got to reach out to us. Because some, cardioversion isn't pleasant. Ablation sure as heck ain't pleasant. But if we're doing that, they're symptomatic. So great questions. All right, so group 6 has premature beats, which I'm going to preface this is that PVCs and PACs, they're not a rhythm. They're a component of a rhythm. So it could be like normal sinus rhythm with a PVC. Like we see that. It's just, okay, I'm gonna let 6 take it away. Go ahead. maybe.
Okay, so like you mentioned, it is an extra beat. The rhythm is underlying the whatever the rhythm the heart already has, and it's caused by an electrical heart signal that is either too early or extra. Um, the P wave visibility depends on the timing of the PVC, but it may be absent. It is in the front of the QRS. The PR interval is less than 0.12 seconds, and the QRS is longer than 0.12. It is bizarre and abnormal looking. The causes is physical and emotional stress, drinking caffeine, tea, or alcohol. It can be cause for any type of medications, like for colds and allergies. It is not there, but it can also be for an underlying disease. The screening, you can use the 12 LED ECG. You should keep a diary of what triggers that extra beat or the absence of the beat. And there are some medications such as calcium channel blockers and beta blockers. They usually use beta blockers, which treats hypertension. And for nursing interventions is we couldn't find like anything, but it says that to educate the patients about lifestyle changes, such as drinking less coffee, tea, and alcohol, and educate the patient on coping with stressors. Basically, if they have like a stressful job or they are putting too much like a workload, they should just avoid those type of things and monitor vital signs, because it is very difficult to find out that you have a PVC. It's just for a doctor, it's just very hard to find if you are suffering of that, and treat the underlying cause. In severe cases, this can cause like either like a infarct or a myocardial infarction or something, but usually this doesn't happen, and it doesn't respect age. You can have it at any time.
Yeah, 100%. So PACs are premature atrial contractions. So basically we kind of got like an extra kick. We got kind of like two P waves. The atria fired twice. And then with PVCs, the ventricle did. So with PVCs, they're kind of like, they're below, they go in the opposite direction. It's like an extra kick. These really aren't, they're more of an incidental finding. They typically are not harmful. We don't really treat them unless it gets to be like every other beat. That's what we call bigeminy. That would be something we would do that for. But more often than not, we just kind of ignore it. So it just comes earlier than expected, and it usually goes in the opposite way of the T wave. So sometimes it could be upright, and sometimes it can be upside down. So usually caffeine, any type of stimulants, over the counter like exercise supplements, those are very common for causing like tachycardia and little flutters, little extra kicks. Sometimes you feel it, sometimes you don't. All right. Let us get into the world of heart blocks. That's probably what's going to stress you guys out the most. All right, group 9.
All right, I think I can probably do the talking for us. Let me pull up a document, or here we go. So yeah, it's just first degree heart blocks. Usually characterized by disjointed like P waves. They're just longer than usual, so longer than like 0.2 seconds from the QRS. They're usually asymptomatic, normally caused by things like cardiac medications, but important that you don't stop your meds. You know, you can keep taking your meds, but that's usually what causes them. There's usually not any kind of treatment that's ever given. I think I was reading that they might give treatment if, what was it? If the P wave, the beginning of the P wave is really far from the QRS complex, but usually no treatment for this. And as far as nursing interventions, we just educate them, continue to observe them, and that's pretty much it, unless I missed something.
No, you got the boring one.
Yeah, it was super easy and really boring, yeah.
So first degree heart block is basically sinus rhythm, except our P wave is too far away from the QRS. So the rhyme is, if the R is far from P, then you have a first degree. So if we were to measure, which is why we always measure and we always look at the whole strip, my P wave to my QRS is going to be greater than 0.20. That's the characteristic of a first degree heart block. You're typically not symptomatic. It's usually caused by some kind of cardiac med, and we don't do anything about it. We don't stop the meds. We continue to monitor. It's just that there's a conduction error. Error is even the wrong word. It's taken a little bit longer to get there. They're not going to have decreased cardiac output. They're technically in sinus. It's just the PR interval is long. That is it for first degree heart block. So with heart blocks, it's a conduction issue with the electricity. And every heart block has a characteristic that we have that makes it what it is. So first degree, the P is far away from the QRS. That's it. Boring, right? Okay, let's do second degree type 1. This is my favorite rhythm. Group 11.
I can start. Sorry, can you hear me? Okay. So for this one, we just put like your PR interval is going to be longer than normal. QRS less than 1.2. Normal and slow heart rate with present P waves and normal QRS waves that like drop every third or fourth block. And then you want to watch out for like drugs that lead to dysrhythmias. So digoxin and adenosine were the two that we saw. And then you could do like atropine followed by a pacemaker, monitor, the Holter monitor, see that. And then the nurse should just monitor the patient's vitals as well as monitor for symptoms such as dizziness. It didn't really say that there were a lot of like symptoms besides dizziness, so maybe also watching for like risk of falls and stuff like that. And then oxygen could be affected. And then the patient should stay away from magnets and pacemakers in place. And the goal is for the patient to remain free of any new dysrhythmias.
I muted myself. Okay, so second degree type 1. This is what we call a wanky box. So with this, we can be symptomatic or we cannot be symptomatic. We could be totally fine and not even know that it's happening. This is usually, again, caused by some kind of cardiac drug, like she mentioned, DIG, or something along those lines. So we typically stop them, okay, if we determine what's going on. And then they'll get a Holter monitor to determine, like, are we going to type 2 or are we just staying where we are? So we're just going to keep evaluating, but we're going to stop what we were doing before. So with second degree type 1, our PR interval is going to progressively get longer. So when I talked about looking at every single QRS, this is why. So you have a P wave, okay? and then it's measured. It's going to be greater than 0.1, 0.2. Then the next P wave, I look at it, it's even longer. Then I go to my next one and it's longer yet. And then I have another one and I lose it. So if we're looking progressively down the strip, my PR interval is going to get longer, 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 and then it's going to drop. Now you have a Wenckebach. Okay, so we have to look at the whole strip, every PR interval, looking at, it's not, we can't just look at one set, otherwise we'd miss it. So it's going to keep going longer and longer until we don't have a QRS for that P wave. So sometimes it could be like 3 beats, sometimes it could be 4, but it's going to get longer and longer and longer until there isn't one. That's it. Questions on type 1? Second degree type 1? All right, let's do type 2.
So we had type 2. The heart rate is usually slow. It's regular or irregular rhythm. There's 2, 3, or 4 P waves before each QRS. And then it said identical, but I'm not sure what that means. So I put it anyway. PR interval is 0.12 to 0.20 seconds, and the QRS is less than 0.12 seconds.
And then as far as causes, I read up on Dr. Google that it talks about natural aging process. It could be due to any damage from the heart, whether that's from heart surgery or an MI. Also could be due to low thyroid levels or electrolyte abnormalities. And then it said that also the most common cause was an anterior MI. And then as far as treatment, a pacemaker, an immediate transcutaneous pacing or transvenous pacing, or atropine push, or a dopamine or epinephrine infusion.
And then for nursing interventions, we want to monitor vital signs, place a patient on a cardiac monitor, obtain an ECG, assess oxygenation, collect labs to ensure electrolytes are within normal limits, place the patient on bed rest, listen to the heart for murmurs, monitor for fluid retention, weigh the patient, hold medications that can disrupt cardiac rhythms. And that's going to be usually beta blockers and antiarrhythmics. If the patient has to have a pacemaker placed, then educate the patient and keep the patient NPO.
Okay. So type 2, second degree type 2 is much more serious than the other two. Okay. We're going to act pretty quickly on this. So the easiest way to identify second degree type 2 is that basically we have more P waves than QRSs. So there'll be P, QRS, T, P, QRS. We have P wave, no QRS. P wave, no QRS. Those QRSs are not getting through. If we look at it though, the QRSs that we do have are pretty regular, but when we're missing, we're missing. Our PR interval is pretty much normal. Whereas with second degree type 1, it got longer and longer and longer. With second degree type 2, our PR interval is actually where it should be. It's between 0.12 and 0.2. So that wouldn't be off. So with type 1, it's greater than 0.2. With second degree type 1, it's longer, 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 and then we don't have anything. And with second degree, it's normal, but we're missing QRSs. We definitely need to treat this one. So it's going to get some kind of pacing and medications to kind of help with this one. So it looks like the Shane Stokes of cardiac rhythms. It's a good analogy. Where you go apneic? Yeah. Okay. So then let's do type 3, third degree heart block. And we got a lot of information here because group 3 knows because they presented it or going to be presenting it. This is like one of those OSH rhythms. This is one that should freak you out a little bit if you see this. So, okay.
Let me just pull up our thing.
So for the characteristics, we have it as, can you hear me? Okay. No atrial impulse is conducted through the AV node into the ventricles. 2 impulses stimulate the heart, 1 stimulates the ventricles, and 1 stimulates the atria. Ventricular and atrial rates depend on the escape rhythm and underlying atrial rhythm. The ventricular rate is lower than the atrial rate. It's usually less than 45 to 50 beats per minute. Ventricular and atrial rhythm, the PP intervals are regular, the RR intervals are regular, PP intervals are not equal to the RR intervals. QRS shape and duration is dependent on the escape rhythm, junctional rhythm, and the QRS shape duration is usually normal. The P wave is dependent on the underlying rhythm hidden, and it's usually hidden in the T wave. PR intervals are typically regular, and the P-QRS ratio, you have more P waves than you do QRS waves. And then for the causes, we have digitalis toxicity, damage to the heart from surgery, damage to the heart muscle from a heart attack, other types of heart disease that result in heart muscle damage. You can have valve disease and other diseases like rheumatic fever, or I don't know how to say this, sarcoidosis. Treatments that we would do would be an atropine push, dopamine or epinephrine infusion. You might need a pacemaker and possibly a transcutaneous one while you're waiting for a permanent one. If the patient has no pulse, the treatment is the same as for ventricular asystole. We're directing the treatment towards increasing the heart rate to maintain a normal cardiac output and decrease or eliminate the cause. And then just the IV bolus and stuff is of atropine is something that they might do in getting you ready for a pacemaker. Nursing considerations, you're going to evaluate the vitals on an ongoing basis, determine dysrhythmias, so you can know what hemodynamic effects are happening. Ask the patients about symptoms of dysrhythmias. You're going to do an EKG, monitor any changes. Possible anti-dysrhythmic medications can be used. We read that you can do a 6-minute walk test if it's prescribed, and you can identify the ventricular rate if you do that. And you're going to assess for any factors that can contribute to dysrhythmias.
Yeah, so 3rd degree heart block is a major deal. Okay, so with 3rd degree heart block, we have a very slow heart rate. Okay, it's usually, I can't say always, but it's usually under 40. Okay, the key to 3rd degree heart block is basically our P's and our Q's are divorced. They are not talking, they are not friends, they are not co-parenting well at all. The P wave does what the P wave does, so the atria does what the atria wants, and the ventricle does what the ventricle wants. It makes no sense. So we'll have P waves and the QRS, and then the P wave will fire another one, but there won't be a QRS for it. And then maybe it'll fire whenever it wants to. So if the P's and Q's don't agree, then you have a 3rd degree. So low heart rate, nothing makes sense with our P's and our QRSs. We need to get these patients treated very quickly. So they need the transcutaneous pacing or like right into surgery. Medications can help with this in the meantime. They're typically very symptomatic in terms of like low level of consciousness, not very strong in terms of what they're able to do. Not a lot of energy because they're not perfusing. The atria is doing what the atria wants, the ventricle is doing what the ventricle wants, and they don't care. So this is the divorced couple of heart blocks. All right, questions on 3rd degrees?
Is there, I just have a question. Is there any other place in ATI that talks about the 3rd degrees? We were only able to find stuff in the big, huge book. Is there anywhere else?
That I don't know. I don't recall seeing anything in there.
Okay.
But I do know that they're putting more heart blocks on NCLEX, where in the past they didn't, and now they are. So.
That was my next question. So for the exam, do we have to memorize the terms or just be familiar with the ECGs, with how they look at the monitor and the description too?
So the pictures will not load on ATI. So we can't put actual strips on there, but you might on your mastery exam next semester see them, or on your NCLEX. So you have to be comfortable what they look like. We didn't get to it yet, but VTAC and VFib are two rhythms you absolutely, positively, 100% need to be able to recognize and be like, that's VFib. In terms of our exams, it's going to be, we'll describe the characteristics of the rhythm, or we'll say, your patient is found to be in VTAC. What is your priority intervention? Something along those lines. So you still need to know all the characteristics of the rhythm. And at some point you may see the actual squiggly lines, but on this exam, we can't get them to work. So you do need to know it, but it won't be, the picture won't be on the exam.
Thank you.
Okay. So the last few rhythms, these are what I call the OSH rhythms, because when I see these, I start to get a little tingly and not in a good way. So let's kick it off with the VTAC. Who had VTAC?
I'll go. So we had VTAC. Yeah, it's an irregular rhythm. Your heart rate is going to be high, between 140 and 180. The P wave is not usually seen. The PR interval is not identifiable, and the QRS complex is wide. It just looks like a giant squiggly line. This is definitely an emergency situation. This rhythm will not be compatible with life if it goes on for a long time. The potential causes are cardiomyopathy, heart failure, myocarditis, improper electrical activity in the ventricles, electrolyte abnormalities, specifically hypokalemia, any heart conditions that can cause scarring of the heart tissue, and this is considered structural heart disease. And then we actually had a question for you, if like a drug overdose from like stimulants can cause VTACs, but then in our reading we said it could also be caused by opioids, or if they're given naloxone to like reverse the opioids, it can cause VTAC.
Drugs in general.
Okay. And then the treatment, I mean, essentially, you know, least invasive to non-invasive, we want to try to get them to bear down. But if that doesn't work, we want to administer the amiodarone, the like stop and restart your heart. And then if there's no pulse, we want to immediately defibrillate the patient and begin CPR. Potentially, we will add a calcium channel blocker or beta blocker with the antiarrhythmic. But yeah, the nursing considerations, like this person is going to die if we don't intervene. So begin CPR. We want to assess for, you know, the risks of decreased cardiac output, decreased perfusion. So all the signs and symptoms that are related to those. Administer oxygen, you know, watch their EKGs. Hopefully, once they're stable, you know, the goal for this patient is to have a regular pulse. And then there's like terms, sustained VTAC is if they are in VTAC for less than 30 seconds, and unsustained equals they're in VTAC for more than 30 seconds. And again, this is life-threatening.
Yes. So VTAC, when you see and determine that your patient truly is in VTAC, the very first thing that you need to do is determine, do they have a pulse or not? Because figuring out if they have a pulse is going to dictate your next course of action. If there's a pulse, we can cardiovert, or we can give them drugs and bear down. If they don't have a pulse, we're going to cardiovert you. This is what we call a shockable rhythm, okay? And by shocking, I mean defibrillate, okay? But if they have a pulse, then it's cardioversion. It's planned and it's synchronized. So we have to determine, is there a pulse or not? You do not see any P waves. They basically look like, kind of like tombstones, in all honesty. You know, they're all upright, squiggly guys going. You might have one every now and then, but this is what it would look like. We can also have what is called a burst of VTAC, where they're in a normal sinus rhythm, and all of a sudden I got like 6 of them in a row. That's called a burst of VTAC. We notify the provider, we look for any identifying causes and go from there. But if it's going on and on and on, we have to do something. All right. Let's talk about the VFib. Group 5.
Okay, I'll do this. So we have VFib, and this is probably the most severe, I would say, because there's absolutely no rhyme or reason to it. Your heart's just wigging out, and they're not even having a pulse because there's no perfusion at all. This is when you see people in the movies and they're just like laying down and somebody starts CPR. So the EKG will be completely erratic, what you see there in the picture. There's no regularities, no identifiable QRS, no P waves, T waves. It just looks completely bonkers. And then we've got the causes of it is cardiomyopathy, damage to the heart muscle, certain hypoxia, acute myocardial infarction, myocardial ischemia, acidosis, electrical injury, drug overdose or toxicity, hypokalemia, hyperkalemia, and sepsis. So it's just pretty much when somebody's really sick and the heart just can't deal with it anymore, it starts wigging out. And then we've got for treatment, main thing, defibrillation. We're going to start CPR, and we have to get that heart moving in some type of rhythm properly, or they're just going to die. And the main thing with the CPR is trying to deal with the heart. Don't worry as much about their breathing. Obviously, if you have 2 people, do what you can with the breathing. But CPR, we're working on the heart. And then trying to shock it if you have an AED, get all of that going. Sometimes through the cycle, you might have the ROSC, which is the heart just starts working again. That's when you stop CPR, or if they're declared dead. So there is a rhythm with it, or a protocol, and I didn't really go through it properly, but with the amiodarone, you only do it 2 times when you're doing the CPR. After that, it's not beneficial. And then we have for the nursing considerations, initiate CPR immediately when you see this, call rapid response team, and then start the defibrillation, the AED, all of that type of stuff, and make sure you're doing it properly, stand clear when they're doing the shocking, and then hope for the best.
Yeah, you explained that perfectly. VFib is chaotic. It's an irregular rhythm, and it's not even so much as a rhythm as just pure chaos. Bunch of squiggly lines going on. Nothing's really happening. It's basically AFib with the ventricles. So with VFib, we defib. That is our goal. We need to get that done right away. But you can't tell what's what. It's just, could be a P wave, could be T wave, who knows, but it's nothing. So that's typically what it looks like. And there is not a pulse associated with this because it's pulseless. Our ventricles are not squeezing, and that's what a pulse is that ventricle squeezing. That's our heart rate. So we don't have that. Medical emergency. This one scares you. First time you see it, you're like, whoo, whoo, whoo. Okay. Let's get on to our last 2 rhythms. Asystole. You guys had a boring one too.
Yeah, ours was pretty boring. It's just basically a flat line. So no ventricular movement and no electrical activity. It's considered complete cardiac arrest.
No heart rate, no rhythm, no P wave, so no PR or QRS flat. It's just a flat line. Let's see. There's a lot of causes. We kind of decided that if you have an irregular heart rhythm and it's not treated, then that can lead to asystole. But some of the most common reasons or causes are blood loss, hypoxia, electrolyte imbalances, dehydration, heart attack, pulmonary embolism, and like I said, irregular heart rhythms. For treatment, it's important to note that it's not a shockable rhythm, and you treat it with high quality BLS / CPR and epi. Some of the nursing considerations we wrote down were to treat the cause if we know the cause as soon as possible. Start CPR really quickly, make sure you have IV access. Just the protocol for giving epi, so 1 milligram IV push every 3 to 5 minutes. Again, just consider those reversible causes if you can. And then if it persists, then the provider can consider ceasing resuscitation.
Yeah, they dead. This rhythm means that they're dead. So contrary to what TV shows you, we cannot shock this rhythm. We are not defibrillating this patient. It will do nothing. So high quality CPR is what we do if we determine that they are in asystole. Okay. So we start with the compressions, we do the drugs, we keep pumping and pumping, and then the machine will tell us shock advised, shock not advised. And this is typically, if they can't get out of that wiggle, then that's it. So, okay. Last but not least, PEA.
Okay, so PEA stands for pulseless electrical activity. So when this is showing up on an EKG, obviously this seems obvious anyways. Your nursing considerations are going to be look at your patient and assess your patient. If your patient is sitting there and talking to you and they're conscious, they are not going to be in PEA. But if they're unconscious, the causes of this can be profound hypovolemia, massive pulmonary emboli, hypothermia, severe hypoxia, overdose, or hyperkalemia. The survival rate of this is only 22%, and your treatment is going to be, you want to do high quality CPR, epinephrine, atropine, and other vasopressor medications. So this is also not a shockable rhythm.
So the key with PEA is that it looks like it should have something to it, but it doesn't. So they'll look like there's like lumps and bumps, but they're not, there's not a pulse present. So it's a form of cardiac arrest that shows like they should have a pulse, but there isn't. They will not have cardiac output to generate a pulse. And there's no oxygen getting to the rest of the body. So we have to start CPR. So with cardiac arrest, which is asystole or PEA, there's some causes that we can fix. And this is, if you've ever heard the term H's and T's, this is what we're talking about. And you learn this in ACLS and like your trauma courses if you take that. But we can reverse it. Hypovolemia, which is volume. Hypoxia, we can fix it. It's H+ acidosis. So if your patient's acidotic, so your hydrogen. Hypo or hyperkalemia can cause arrest. We can fix that. Hypoglycemia or hypothermia. So these are reversible causes of cardiac arrest. And then our T's are tension pneumothoraxes, tamponade, toxins like poison, a thrombosis, or trauma. So that trauma usually coincides with the hypovolemia. So those are the main causes of PEA that we can fix. But yeah, it is not a shockable rhythm. So VFib and pulseless VTAC, we can shock. Asystole and PEA, we cannot. And then other rhythms, we might cardiovert, which is a synchronized shock. All right, those are your rhythms, guys. Those are the ones that we focus on, the ones that you will see the most, the ones that you need to know. There's definitely more, but we don't get into all those. So how do we feel? Mind blown? The key to EKGs and rhythm strips is practice. Now that we learned the characteristics of what it looks like, we can practice. So I kind of want to push through, but does anybody need like 5 minutes to go to the bathroom? I have one last thing left to do that won't take forever, but I don't want to like prolong anybody. So are you guys cool with 5 minutes? All right, I have one more activity. Let's take 5, literally 5. Well, it's 12:38. 12:45, come back. Okay. And then we'll finish up. Okie dokie. Hope you enjoyed the CPR song. That's what I always think of when I'm doing CPR. No joke. All right, so Mara, I think I want to cry. Okay, don't cry. No tears. Not yet, anyway. So, as I mentioned, the key to tele strip interpretation is just practice, and practice makes perfect. So we're going to get there. So we're going to break some strips down together. Okay, real quick. All right, so let me bring this up, and we're going to, okay. Make that nice and big for you guys. And I'm going to share. And we're going to go through this together, step by step. Okay. All right. So first rhythm. First thing I'm going to do is determine my heart rate. So 6-second strips, I can see my little lines. What is my heart rate with this rhythm?
Did we say it was 60 to 100?
Is it 110?
110. So what we're going to do is we're going to count our QRSs within the whole strip. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. 11 times 10 gives us 110. So I have a heart rate of 110. Okay. Next thing I'm going to look at is my rhythm regular? So do my R's, my QRSs, I look at the top, the R's, are they consistently even throughout the strip? This will tell us if my rhythm is regular or irregular. So distance-wise, is it the same? I see a couple yeses. Yeah, it is. My QRSs would march out very nicely if I had a piece of paper and did that. So I have a regular rhythm. Okay, so that kind of takes some of those other rhythms off the table. So now I look, do I have a P wave for every QRS? P wave, P wave, P wave, P wave. Yep, I got it. I got it. So I have a P wave for every QRS. Then I look at the PR interval, which this is difficult to do on a computer, which is why they don't have you measure it. But I'm going to go here. So I have 1, 2, 3, 4-ish little boxes, which would give me a PR interval of what? If the little boxes are 0.04, and I have 4 of them from my P to my QRS, what's 4 times 0.04?
0.16.
0.16.
0.16. So I have a heart rate of 110, a PR interval of 0.16. My QRS, as I'm looking at those, they look normal. 2 boxes, 0.08. What do I think this rhythm is?
Sinus
Normal
tachycardia.
sinus.
What'd you say, Lena?
Oh, sinus tachycardia.
This is sinus tachycardia. So I know it's tachycardia because it's greater than 100. Everything is regular about it. Normal PR interval, normal QRSs, it's a regular rhythm. It's just greater than 110. Sinus tach. Okay. All right. Let's do this next one. So I'm going to look at my rate. What would my heart rate be?
70.
1, 2, 3, 4, 5, 6. Yep. Heart rate is 70. Okay. Is this a regular rhythm? So do my QRSs march out evenly down the strip?
No. No.
I don't even have to have my calipers or a piece of paper to see that they sure don't. So this is an irregular rhythm. Okay. Let me look at my P waves. Do I have a P wave for every QRS?
No,
Why are we saying no? You're not wrong.
there's a lot. The one where there's like the fifth beat has no P wave.
We got a lot of like little things going on in between our QRSs, don't we? So we would not be able to figure out what the PR interval is because here's a P wave, here's a P wave, here's a P wave, here's one, like they're all over the place. So what is this?
Is this a block?
Not a block. I heard it.
AFib, isn't it?
This is AFib. This is an ugly AFib. This isn't as pretty as I would like to see, but basically there's a lot of chaos going in between our irregular QRSs. So if we walked into our patient's room and this was the rhythm that we saw on the monitor, brand new, let's assess them, let's check them out, see if they're symptomatic, and we have to notify somebody. If this is what they come in with, the providers all know about it, this is where they've been living, we wouldn't do much. That heart rate is great. It's a rate of 70, but our P waves are acting a fool. So we got a whole bunch of P waves in there. So we just have to make sure that they're anticoagulated and not symptomatic.
So with AFib, it doesn't matter when the ventricles are contracting as much as it's just the atria are contracting more than they should.
Mm-hmm. They're being bonkers. Okay. So now let's look at this one. What is my heart rate? That's the first thing I figure out. What is my heart rate with this one? Or if you know the answer, you can say the answer. Because some of these rhythms you can look at and you're like, oh, I know what this is. Yep, so we got a heart rate of 190. I got 19 QRSs in that 6-second strip. So that's a high heart rate. Is it regular? Very regular. It is very ba-dum, 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 ba-dum. Okay. Do I have a P wave for every QRS? Are these P waves or are these T waves?
Is the P wave being absorbed and it's a T wave?
Could be. Because what rhythm do we think this is?
Supraventricular tachycardia.
This is SVT. So it's fast, it's regular, it's faster than regular tachycardia. We don't clearly see P waves and T waves. It's hard to discern what's what because everything is so condensed and close together. So that's what that looks like. So this one, I don't want you to figure out. This might throw you for a loop. You guys remember when you're talking about electrolytes and with hyperkalemia, we can have peaked T waves. That's what they're talking about. So our T waves are clearly very tall. They're also very wide. So if you saw this instead of a nice, pretty, well, this isn't even that pretty, nice normal T wave, they're wide and they're tall. We'd check their potassium just to put something to paper or like a picture to what you've learned, because we don't always do that. Okay. So let's do this one. So first and foremost, what is our heart rate? 1, 2, 3, 4, 5. I have 5 QRSs.
50.
Heart rate of 50. Okay. So right away, we're thinking something with a heart rate less than 50. So it's not going to be tachy, not going to be like a fib. Okay. So next I look, is this a regular rhythm? Are my QRSs marching down the line very nicely? They are. So perfect. I have a regular rhythm. Okay. Do I have a P wave for every QRS? I've got a P wave, QRS, P wave, QRS, P wave, QRS. Yeah. Okay. So my next thing I'm going to look at is my PR interval. My P wave starts here and ends all the way over here. So 1, 2, 3, 4, 5, because there's 5 little boxes and besides here. Almost, we got 9 times 0.04. So I'm going to have a rate of 0.27, 0.3, somewhere along there. So I have a really long PR interval. I need to make sure that I'm measuring and that it's consistently down the line, but it's regular. Brady is the slow heart rate, but my PR interval is really long. And like Sierra said, this is a 1st-degree heart block. This is sinus Brady with a 1st-degree heart block. So we just look at that PR interval all the way down the line. Perfect.
What would have to read different on that EKG for it just to be sinus Brady without a heart block?
This P wave would be within that 0.2.
Oh,
It'd be
okay,
a lot
okay.
closer to the QRS. So that's
Okay.
the only difference is where that P wave is. And that's what creates a 1st-degree heart block is the P wave is just too far away.
Okay.
So this one can get missed because we don't always look at that PR interval. Okay. Which one do I want to do next? Let's do the next one. So what's my heart rate?
30 beats per minute?
30 beats per minute. Okay. Is this regular?
Yeah.
So this is. If we look at it, our ventricular rates is even throughout. Okay. Do I have a P wave for every QRS? Kinda. But I also have P waves that are just there with no QRS. Okay. So I can't determine a PR interval because I have P waves without a QRS. It's inconsistent. Okay, that's kind of crummy. And then our QRS is kind of wide. It's a little bit bigger than we would like. So I have a P wave QRS, probably a T. P wave, nothing. P wave, QRS, P wave, QRS. These P waves are doing their own dang thing. What are we thinking with this rhythm?
Is it a 3rd-degree heart block?
This is a 3rd-degree heart block. I have a very low heart rate. My P's and my QRSs, again, they're not talking. P's are doing its thing. Q's are doing its thing. That's where we're at. Okay. All right, so let's do this one. So do I have, what's my heart rate?
70.
Okay, heart rate is 70. Is this regular?
Yes.
Sure is, looks nice. Do I have P's for every QRS? Samantha's like, I think so. I have P's for every QRS, but I definitely have a lot more P's. Okay. So I'm looking at this. It's regular. I got a whole bunch of P waves.
Is this a 2nd-degree block?
This is not a 2nd-degree block.
This flutter? Yeah,
This is
flutter.
So this is that textbook sawtooth where it's like but up in between. And what's interesting about flutter is that, again, the ventricles are still on point. They're doing what they're supposed to do. So they're going to be regular, but we have all these extra P waves in between. But it is very organized compared to AFib, where it's all like bonkers. So it is still a little wonky, but not as wonky as the AFib. Okay. Here's your asystole. First intervention. What do you do first?
Check for a pulse.
Make sure that they're actually, you know, without a pulse and it's not just a lead that fell off, because that can happen. And then initiate high quality CPR. All right. What do we got going on here?
Is that one VTAC?
Not VTAC.
Is that VFib?
This is VFib. So what you have here, you have no P waves, no real QRSs, everything's just kind of shaken. So it's different than asystole, because asystole is kind of just a very like mellow wave. This is just shaking going on. Sometimes it'll be more pronounced, sometimes it'll be more subtle like this. Okay. Let's do this one. So what is my heart rate? 40. Okay. Is this a regular rhythm? Okay, so it's regular. It's heart rate of 40. Do I have a P wave for every QRS? I sure do. So the next thing I'm going to look at is my PR interval. 1, 2, 3-ish. So about 0.12, 0.16-ish. It's kind of hard to tell.
I'm sorry, what are you counting when you count the PRI?
The little boxes from the P wave to the QRS.
Is this sinus Brady?
This is sinus Brady. It looks kind of wonky, but it is sinus Brady. My PR interval is less than 0.2. If it was greater than 0.2, then it would be first degree heart block. But because it's under 0.2, this is just sinus Brady. So the whole key to identifying rhythms is, first of all, knowing what's what, but just following the steps for every rhythm. Sometimes it's going to matter and sometimes it's not. Sometimes you're going to look at something like, I'm going to look at, well, I'll go back up here. No, not that one. This is a good one. I can look at this rhythm, and even without marching it out, I can tell that this is SVT. That's just experience and with practice. Now, for some of these other ones, this is where it gets more complicated. You won't get a rhythm like this. They had a pause. That's what that means. But I would measure everything out, and I would go through my steps every single time. But certain rhythms, you'll just be able to look at and be like, this is what that is. So it's all just about understanding the characteristics and practice. And there are tons and tons of practice strips out there. Don't pay for anything, but just kind of take a look around and kind of try to figure it out.
Is it possible to get this or?
Yeah, I'm going to post everything at the end of the week.
Okay, and the answers will be there too, so we're not learning it the wrong way. Okay.
The answers are on the bottom. The answers are on the bottom, and you'll see some of them and you're like, I have no idea what an idioventricular rhythm is. It's okay. All right. All right, so let's take a look at this last one. So what is my heart rate here?
50.
50. Okay. So then I'm going to look at, is this regular? It's not. My QRSs, they seemed like they were good for a while, but it's not consistently regular. So it's an irregular rhythm. Okay. So now I'm going to look, do I have a P wave for every QRS? Yep. Oh, I don't have a QRS here though, but I have a P wave QRS, P wave QRS, P wave QRS. Okay. So there's P waves. My next thing is I'm going to look at my PR interval. So I'm going to measure from the start of the P to the QRS. So I got 1, 2, I got about 6 boxes. Okay. Now I'm going to measure from the next one. And I got 1, 2, 3, 4, 5, 6, 7, 8, 9. So I got longer. Then I go to my next P wave and I don't have anything. I start again. 1, 2, 3, 4, 5. This one has 6. This one has like 8. And then this one doesn't have anything. Any guesses what this one would be?
I
Is
think
this
it's a
the
third
married
degree block.
couple, the divorced couple?
Not the divorced couple. Haley's got it. This is a second degree type 1. So my PR interval gets longer, and then it drops. I don't have that QRS. Long, longer, drop. It's consistent throughout.
Do we
Is this
know that
one-
that's called the Winnie back as well?
is
Do
the
we
Winnie
need to know
back.
both of those? Or
Yeah, I mean, you hear them called both because people get really confused with Mobitz type 1, Mobitz type 2. So the Winky bot kind of, it's the guy who discovered it. I don't know. Either or.
So I'm confused. When you're looking at it, what's the difference? Like if you're visually looking at it between a type 1 and a type 2 heart block?
So this is the type 1 where we see the PR getting longer and longer, then it goes away. This is a second degree type 2 where my PR interval is normal. So if I counted this out, I'm at about 4 boxes with this. So it'd be 0.16. And this one, I don't have a QRS. It didn't get through. Then I measure this one and it's still 0.4. So what's happening is my PR interval, when it's there, is normal, but I have a P wave with no QRS consistently. Does that kind of make more sense?
Yeah, and then the type 1, the PR interval is not the same.
The PR interval is
Consistent.
it's going to be really long throughout.
Okay.
It's going to be greater than 0.2. It'll be sinus rhythm or sinus Brady, but that PR interval is going to be too long in each of them.
Okay.
So hopefully nobody wants to cry too much. I have one funny thing to show you, and then I'm going to let you rest and digest all of this because I know it's a lot. So one of my favorite things to do is just to like laugh. Okay. And I want to share with you a video that kind of just makes me giggle. And I'm going to have to mute this because it's going to have an ad pop up. Okay. So if EKGs were songs, apparently, what is going on here? Stop it.
But everything and anything about a boom, about a thing, I gotta do a lot of things to make it clear. Si el ritmo te lleva a mover la cabeza, yo drop it like it's hot, drop it like it's hot, drop it like it's hot.
I don't know. That makes me laugh hysterically like every time I watch it. There's another one too. So I'll post that for you guys because I don't know. Now I always think when I hear those songs, I think about those heart rhythms or like what happens. So with type 2, it drops. It's not there. It's not there. It's not there. And then type 1, longer. So that's the way my mind works. Hopefully you got some giggles out of it. Okay. So I'm going to post a whole bunch of resources for you guys. They also have some EKG stuff usually in the CTL. some learning stuff with Dr. Haskell, which is very, very helpful. If we need extra tutoring or extra questions, please reach out to me. This is one of the things I actually really like. So I'm like all about this. You can keep your babies and all that kind of stuff. I like rhythms. So otherwise, enjoy the rest of your day. Go take the last few minutes and just kind of recoup, because again, I know this was a lot.
Thank you.
You're welcome.
Thank you.
Thank you.
Thank you.
I just wanted to ask something about the homework, where we write the NCLEX questions. When it says specific to the content, I've just been looking in like my NCLEX book and putting cardiovascular questions that are in that section. Do you want more specific to like exactly what we're learning on that week?
Yes. So if we're doing stuff on like the heart valves or whatever, don't give me something on hypertension, because we didn't do it yet, or something like that. It should be relative to what we're doing. And I kind of tell people, like, if you screwed up the question, let's say on chest tubes, do another one on chest tubes to kind of help solidify it.
Okay. And Google is okay to just look up questions on there, just like Google NCLEX questions about specific topics.
Yeah, whatever works, and then kind of just tweak it to how you think would work if you need to, and go from there.
Okay. Thank you.
You're welcome.